Come on in, you guys. We got a brand new episode of Jimmy Rants in store for you here today. JimmyRants.com is the website, and as always, you can engage live in the content, but you got to go follow me. I'm over on Instagram. I am at Living Low Carb Man, LIVINLOWCARBMAN. Once you are there, please go check it out. We do this show Monday through Friday, 11 a.m. Eastern Time on Instagram Live, so go check me out there. If you missed the live, it's okay. They leave it up for 24 hours so you can watch the replay. But after 24 hours, it does disappear. You'll need to pop on over to JimmyRants.com. That's where we house all the past episodes. Or you can pop on over to YouTube, who we're also simulcasting on YouTube Live as well as Facebook Live. You can go check it out, you guys, over at YouTube. Type in a keyword, Jimmy Rants. You will find the show. So guys, I got a really great show in store for you here today because there is a brand new paper that was published in a medical journal, pharmaceutical journal is what it's called. And it's the three authors. I know all three of these people personally. Is Marianne Damasi. She's an investigative medical reporter from Australia. Dr. Robert Lustig is a professor of pediatrics at the University of California, San Francisco. Dr. Lustig very famously did a YouTube video that went viral all about Sugar, the Bitter Truth. So if you've never seen his Sugar, the Bitter Truth video, go look it up on YouTube. And then Dr. Aseem Malhotra is a cardiologist out of the UK who's been making a lot of noise lately trying to underscore this whole idea that metabolic disease is the crisis we're dealing with. And in the midst of this COVID-19 pandemic, a lot of people are saying a lot of things, but what we're seeing is, at least from the data, is a lot of the people who are most susceptible to COVID-19 are tending to be the people that are metabolically unhealthy. So then the question becomes, why are people metabolically unhealthy? What is it about what they're doing that's making them metabolically unhealthy? And it really comes down to two major things that people believe when it comes to health. So think about these things for a moment. Think about all the beliefs you have about nutritional health, okay? It comes down to two major things, especially those of us that start on a ketogenic diet. Two major things pop up really, really fast. When you talk about eating a low-carb, high-fat diet like keto, it's two things. Cholesterol, people all worry about the cholesterol. Oh, my cholesterol is going to go higher and higher, and so my cholesterol means something in my health. Like if I have cholesterol go up over 200, I'm going to die of a heart attack and heart disease and da-da-da-da-da. That's one. The other thing is, well, if I eat all that fat on a ketogenic diet, that is a lot of calories, and so I'm going to just gain weight and balloon up. So what I want to share with you here today is this paper that was written in Pharmaceutical Journal by Marianne Damasi, who is a doctor as well, Dr. Lustig and Dr. Malhotra, where they make the case that the cholesterol and calorie hypotheses are both dead. Dead as a doornail. Like forever we have been told the relevance of the two C's, cholesterol and calories. And honestly, neither one really had any credence, at least from the scientific realm. Neither cholesterol nor calories have ever really mattered when it comes to your health. And yet, look at what doctors focus on. Look at what nutritionists and dietitians focus on. Doctors say, well, don't get that cholesterol too high. You're going to die of a heart attack. And then dietitians say, oh, you don't want to eat too many calories. You have too many calories. You're going to gain weight. You're going to have health problems, blah, 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 blah. So those are the things that have been out there. And if you're just joining us, I'm about to read from a paper in the Pharmaceutical Journal that was just published. And it was by three medical doctors, Dr. Marianne Damasi, Dr. Robert Lustig, and Dr. Aseem Malhotra. And they make the case that it's not about cholesterol and it's not about calories at all. They say both of those hypotheses are dead on arrival. Instead, it's time to focus on the real culprit in your health. You ready for this? It's insulin resistance. Now, I told you Dr. Malhotra has been getting all over television over in the UK, making a big stink about COVID-19 and the relationship that people who are getting it and getting the most severe symptoms. One thing that he has repeated often, and I kind of called him out about it, is he's saying that it's obesity that is the reason why people are susceptible. And I don't think it's obesity alone that's doing that. I think it is the insulin resistance that goes along with it. And I suppose since most people who are obese also tend to have metabolic damage and insulin resistance, that he feels like, okay, let me say obesity and that'll get people's attention. Whereas if you say insulin resistance, not everybody will immediately recognize that they're insulin resistant. So I get why he's doing that, but on this paper, they put a fine point on insulin resistance. You guys ready to read for me to read this? Aggressive lowering of low-density lipoprotein cholesterol, that's the LDL, has been the cornerstone of preventative cardiology for decades. Statin drugs are widely used as the go-to solution for the prevention of heart disease owing to their ability to be able to slash your LDL-C levels, which is a surrogate marker of cardiovascular disease. Indeed, statins are one of the most widely prescribed class of drugs in the world, to the tune of $29 billion a year they make selling those drugs. But this phenomenon begs two specific questions. Is the enthusiasm for aggressive lowering of LDL justified? Good question. And is a pharmacotherapy superior to a lifestyle intervention? That's the thing that's always kind of baffled me when it comes to cholesterol. Rather than telling patients, okay, if we think LDL-C means something, and we feel like there's a natural way to lower that LDL-C, why aren't we telling patients to do that? And here's the funny part. If you care about your LDL-C and you do think it's a relevant marker in your health, you want to know what the best way to lower LDL-C is? It's going to shock you. You ready? The best way to lower your LDL-C number, which is an estimated calculated number, the best way is to drink vegetable oil and eat refined carbohydrates. What? That lowers LDL? What? Yep. In fact, Dave Feldman was the one that did the experiment. He wanted to see what would happen to his LDL cholesterol if he basically ate junk food for a period of time, and then he tested his cholesterol both before and after. And you can drop your cholesterol extremely fast eating refined carbohydrates, your LDL cholesterol. Shocking, right? Of course, what happens to your triglycerides? Way, way, way up. And what happens to the quality of the LDL particles, which you can tease that out with an NMR lipoprofile test. You can see that it shifts your body over from like this mostly large fluffy kind of LDL over to the more atherogenic small dense LDL. But if a doctor is only looking at LDL-C as the only number in your heart health, he's going to miss that. Same with, he's going to miss that if you did a lifestyle intervention like keto, then you could make that shift over to that pattern A, which is the very healthy form of LDL, and less of the pattern B, which is those small BB LDL particles that penetrate the arterial wall and give you heart disease. Great questions that they're asking in this paper. Over the years, medical guidelines have continually expanded the number of individuals for whom statin therapy is recommended. Yeah, when they first started, I think the total cholesterol was like 225, 230, and it eventually made its way down to 200 as total cholesterol. You want to know what they're trying to propose now? They want to get it down as low as 170 for total cholesterol. Now, guys, when you get below 140 in total cholesterol, you're talking about mental health damage and effects happening. It's scary what they're doing with cholesterol, but the reason they're doing it is people have obediently made things happen in their diet and by taking statin drugs that they have to lower it in order to get more people to go on the statin drugs some more. It's pretty bad. By the way, I wrote a book about cholesterol called Cholesterol Clarity, What the HDL is Wrong with My Numbers. If you want to check it out, I've got quite a bit of knowledge about cholesterol. Released that book right at 7 years ago, and it's still relevant to this day because we still worry about LDL. Proponents argue that statins are a lifesaver and that people will die if they discontinue their medicine. They have said that. This is how doctors get patients to obediently take these drugs that are poisoning their body. They say, you know what, if you don't take this, you're going to get a heart attack. What they're not telling the patients is if you take this drug, you will very likely have joint pain and muscle aches. That's reported by a lot of people, like vast majority of people get this. What that is your body is basically having the CoQ10 sucked out of your body. And CoQ10 is kind of a key element in your muscles and everything. And so you start getting joint pain and muscle aches because this CoQ10 is being leached out of your body. So that's major. But even on a more major scale of your risk factor, you increase your risk of diabetes by about 15%. You increase your risk of cancer by about 10%. And oh yeah, that thing it's supposed to prevent, heart disease, taking a statin medication actually raises your risk of heart disease by 12%. So the very thing it's supposed to be preventing, it's actually helping to cause happen. Ironic, huh? So when they say things like, oh, it's a lifesaver and people will die if you don't take it, I think you're more susceptible to dying if you do take it than if you don't take it. In fact, they did a study, and there's this thing called numbers needed to treat. So with statin medications, they looked for what is that numbers needed to treat. In other words, how many patients have to take a medication in order for one to see a benefit? You want to know what the numbers needed to treat for statin medications is? Is it 1 in 5, which would be 20%? No. Is it 1 in 50? No. How about 1 in 100? So in other words, for every 100 people that take a statin medication, one person gets benefit out of it. The other 99 only get negative adverse reactions through all the muscle aches and pains and all these increased risk factors. Is that worth it to you with a 1% chance that it could possibly maybe give you a benefit? I don't know about you, but I don't want to do 1% of anything. If they had like 100 chambers on a gun and they said Russian roulette, you want me to pull the trigger when I only have one chance that it won't have a bullet in it? Come on. Like, who would do that? But people do it every day with a statin medication because doctors scare the bejeebies out of you about it. Prominent researchers from reputable universities have declared that everyone over 50 should be on a statin to reduce their risk of cardiovascular disease, and that even children with a high LDL as young as 8 years old should be afforded statin therapy. Oh my God. Like, seriously, sheesh. And I'll be danged, I'm 48 now. I'll be danged if they make me take a statin medication, because what we've seen, especially with this COVID-19 thing that came out, the people that have the higher cholesterol are tending to do better because the first thing this COVID-19 does when it gets into your system is it greatly lowers your cholesterol levels. It just starts eating it up. And I think that's where the cholesterol is probably trying to help with the inflammation, because that's what cholesterol's role is in the body. It's not to clog your arteries. It's actually to go to the scene of where inflammation is taking place. So when COVID-19 comes into the body, there is a cascade of inflammatory markers starting to go crazy. Well, then the cholesterol is coming in to try to deal with that, along with your immune system fighting off the virus. And so, I don't know about you, I'd rather have very high cholesterol than I would very low cholesterol under that auspice. The true benefit of statins is in altering the risk of cardiovascular disease is increasingly being questioned by respected members of the medical community, which is creating bitter divisions within the ranks. Several cardiologists have countered that the benefits of statins have been grossly exaggerated, especially to use as a primary prevention. In other words, they're putting people on statin medications, not who have had a cardiovascular event, not who have had a heart attack or have heart disease. They're putting it on people to prevent heart attacks and disease. And so the preventative nature of this is being widely overused, they're saying. While their risks have been consistently underemphasized. So some of those increased risks of various things that I talked about earlier, and then the widely reported probably upwards of 85 to 90% of people getting muscle aches and joint pains and that kind of thing. The funny part is people who take those drugs and they start getting the muscle aches and pains, I know a lot of them, they just chalk it up, well, I'm older. I guess this is what it's supposed to feel like when you get older. Got creaky elbows and creaky knees. Not realizing all along that it was the statin medication. In fact, used to have a neighbor over there who took statin medications, and she read my book, Cholesterol Clarity, saw chapter 5 where it talked about statins and their effects, and she's like, oh my gosh, I think I'm having negative effects from taking the medication. She came off the medication, and within just like a week or two, all of her joint pain that she thought was just getting older got better. It's powerful, you guys. And maybe this is something that you started taking a statin because your doctor warned you about keto. Well, at least take a statin, so blah, blah, blah. And so you're starting to have these joint pains, and you're going, man, this keto is horrible. It's making my joint pain worse. No, it's the statin medication that's doing that. While their risks have been underemphasized, in some quarters, the skepticism about statins has reached a fevered pitch. Some say that the preponderance of the statin trials has been tainted by industry sponsorship. That's true. A lot of the statin drug trials are bought and paid for by the companies making Lipitor. I think that's Pfizer makes Lipitor, Crestor, all the statin classification of drugs. They're paying for the studies. Here's the thing that ticks me off to no end, just in general about health studies. If it's paid for by an industry, but they're not getting the result they want, they are not required to have to publish those results. In other words, these companies paying lots of money to get this research, they hope for a certain outcome. And so if that outcome does not come out in the study when they're doing it, they'll just scrap the study as if it never happened. To me, that's wrong. I think for us as consumers, we don't need to have cherry-picked data. We need to see all the data. And if there is a trial that shows people are dying because they're taking a statin medication, you bet we want to see that study. But the problem is they're paying for the study, and if they release that study and do it honestly, it will cut into their bottom line. Who wants to take a drug that has a 15% chance of killing you, for example? So that's unfortunate, but that is happening rampantly, you guys. If you didn't know that was happening, now you do. Not all the studies that are being done actually get published. And it's those unpublished ones. I wish that they were forced by the NIH, National Institutes of Health, to release all the studies, but they're not. And that's sad. But not all of them are bought and paid for by industry. And some of the better studies that are looking at this are the ones, unfortunately, that are not paid for by statin drug companies. They're influenced by statistical deception. What's the one? Lipitor used to air a commercial where they said, if you take Lipitor, you'll see a 40% drop in your LDL. Well, the thing is, that was like not the actual drop. People thought 40%, wow, that dropped. No, it's the relative change between the numbers, not the actual change. And so it's funny how they use all those math games, and the consumer gets caught in the middle of it trying to figure out what they mean. Also riddled with flawed methodology. So those who challenge the cholesterol hypothesis, and I'm one of those, are accused of cherry-picking the data. Ironically, though, it's pro-statin researchers themselves who are guilty of cherry-picking. There was an article in the Lancet published in 2016. It purported to end the statin debate, ostensibly to silence dissenting views. Yet, despite billions of dollars invested in developing all these medications to reduce LDL-C drastically, there remains no consistent evidence for a clinical benefit with respect to either events or mortality. I'll tell you how these statin drugs work. And they first came out and they were pushed as, okay, they're going to help you lower your cholesterol. That's how they were pitched. So consumers, oh, cholesterol's the enemy. Oh. And so they start taking these meds. Well, what they found was people lowered their cholesterol, but they still were having heart attacks. They lowered their cholesterol and they were still having heart disease develop. So what's going on? What they did was they said, okay, look, it's not the cholesterol lowering effects, it's actually the inflammation lowering effects that statin drugs do. And so now they're pushing these medications like Lipitor and Crestor as not just cholesterol lowering, but also inflammation lowering. The problem with that is they pretend like you need to lower inflammation with a drug. There are a lot of things that will lower inflammation naturally. Lots of supplements, lots of adaptogens, and oh yeah, by the way, a ketogenic diet does the same thing. So why are we putting people on a drug with known side effects and risks and not telling them about keto and these other natural ways to lower inflammation? And that's the bottom line. Most of this is all inflammation driven. And if you get the inflammation down, you don't worry about cardiovascular disease or any chronic disease. There are 44 randomized controlled trials, that is the gold standard in research, of drug and dietary interventions to lower your LDL-C in primary and secondary literature, which shows no benefit on your mortality. In other words, they look to see if lowering LDL-C kept you from dying. It does not. 44 different RCTs. Most of these trials did not reduce your cardiovascular event whatsoever. Several, in fact, reported substantial harm, which again, looking at people that have lower cholesterol, they're still having heart attacks. In fact, one of the studies that we put in Cholesterol Clarity was that when they looked at patients who came into an emergency room and they looked at patients who were having like angina, chest pain, and other heart attack, all kinds of things. It came to the ER. What percentage do you think those people had high cholesterol? Because if high cholesterol is the reason you have a cardiovascular event, then you would think most of those people would have high cholesterol. Would you believe only 50% of them had high cholesterol? The other 50% had cholesterol under 200 and yet still had this cardiovascular event. So if high cholesterol is the cause, why, pray tell, did that happen? These studies have not really gotten much publicity. Furthermore, the Accelerate trial, which was a recent, well-conducted, double-blind, randomized controlled trial, again, a very good study, demonstrated there was no discernible reduction in cardiovascular events or mortality despite a 130% increase in HDL cholesterol and a 37% drop in LDL cholesterol. The result dumbfounded the experts, sparking a renewed skepticism about the veracity of the cholesterol hypothesis. Again, I could wax eloquently for hours all about the flaws in cholesterol. If this is of interest to you and you don't really know a lot about it, I did write a whole book about it in layman's language, Cholesterol Clarity. Go get it on Amazon. It's in hardback, Kindle, and audiobook if you can put up with my voice for, I think it's 8 hours long. There also appears to be no clear reduction in coronary heart disease and mortality in Western European countries from taking statins for either primary or secondary prevention. More recently, a post hoc analysis showed that there was no benefit of taking statins in elderly people with moderate it says hyperlipidemia and hypertension. So that's high cholesterol and high blood pressure. In primary prevention, a non-significant direction toward increased all-cause mortality among adults 75 and older. Here's the funny thing about 75 and older. Those people are supposed to have high cholesterol. I cited this in Cholesterol Clarity when they looked at like traditional cultures free from heart disease, most of the older population in their 60s, 70s, 80s, they looked at their average cholesterol. Now keep in mind, these societies free from heart disease, none, zero. And so in the older people in these cultures, they tested their cholesterol. You want to know what the average normal cholesterol is? 60s, 70s, and 80-year-old people? It's 300. Now, the doctor saw a 75-year-old woman come into his office and have a 300 total cholesterol. He couldn't write the prescription for Lipitor fast enough. And yet there's no evidence that that's going to give her any benefit whatsoever. That cholesterol is serving a good purpose in the older population, which again, cholesterol is not the enemy. An assessment of industry-sponsored RCTs, in other words, the pharmaceutical companies who have a stake in it, they do some randomized controlled trials, showed the median increase in life expectancy for the participants in their secondary prevention trials who adhered to taking statins every day for several years. They increased their lifespan by 4 days. 4 whole friggin' days. So did they increase lifespan? Yeah. But never mind, they had muscle aches and pains and memory loss and on and on and on from these statin medications. 4 days. Like, did they really publish 4 days was like how we increase your lifespan? Is it 4 miserable days? Like, is it 4 days in quarantine? Like, that would not be very helpful. Similarly, the recent report of the efficacy of the latest blockbuster drug called evolocumab, Repatha, which is a PCSK9 inhibitor, was quite underwhelming despite all the media hype. Published in the New England Journal of Medicine, the paper reported that this, combined with a statin, lowered your LDL by a whopping 60%, but yet it translated into only a 1.5% reduction in non-fatal cardiovascular events. So it lowers cholesterol, absolutely. But did CVD go down? Nope, sure did not. Furthermore, this drug did not reduce total or cardiovascular mortality. Rather, there was a non-significant increase in mortality. So basically, it stayed the same compared with placebo, and a non-statistically significant increase in overall mortality in the experimental group compared to with placebo. In other words, no effect. Was no difference than if they took no drugs than if they took this drug. And if the whole point of this drug was to protect against cardiovascular disease and the deaths by which those would happen as a result, it did neither. Put simply, none of the patients who took the drug lived any longer than those who took the placebo. While the drug might synergize with a statin to prevent a non-fatal heart attack, it seems to increase the risk of some other equally life-threatening pathology, which kills the patient. As noted in an article in the Daily Telegraph, May 2017, European participants in the trial saw no benefit in preventing any hard outcomes. So, when you look at the totality of the evidence, the sobering results of these studies has left many doctors wondering whether the directive to lower LDL-C aggressively with drugs has been misguided. Big Pharma has certainly triumphed, and yet the patients have not. Think about it. Pharmaceutical companies have made annually, since the statin drugs came out, annually $29 billion a year. They don't want to lose this cash cow. They want nothing to do with saying that cholesterol is irrelevant as a health marker. They want doctors to obsess. And so you know how they get the doctors. They say, you know what, if you prescribe our drug, we'll give you a kickback. That's one way. Or, you know, we would really love to have you on board. Why don't you come speak at our conference? We'll pay for you to be up in a lush hotel, and we'll have all the accommodations. Bring your whole family with you. We'll even give you a little speaker fee, and you just keep being a doctor out there that pushes statins for us, and we'll keep giving you a gravy train. And they do that over and over and over with lots of doctors. And that's how they lure them in. And that's how they fool consumers into thinking that this is some kind of a good preventative care measure for heart disease, when taking a statin has never been about that. We've been bamboozled, you guys, when it comes to cholesterol, which is why the authors in this paper here are saying that the cholesterol hypothesis is pretty much dead. There's no evidence to show it gives any benefit whatsoever to care about your cholesterol. Yet if you ask most people, most know what their cholesterol is right off the top of their head. And then you kind of go, well, what's that mean? Well, I guess I'm at higher risk because it's 215. No, you're not. But that's what we deal with. There is an ethical and moral imperative that the true benefits and the potential harms of all these drugs are discussed to protect patients from unnecessary anxiety, manipulation, and other complications. Furthermore, contrary to reports about stopping statins as a consequence of media scare stories about side effects resulting in thousands of heart attacks and deaths, there is no scientific evidence from registry data of one single person seeing this fate happen. One of the most compelling arguments against the LDL-C as the primary target of CVD prevention is what's called the Lion Diet Heart Study. That's Lyon, Diet Heart Study. Adopting a Mediterranean diet for secondary prevention improved both recurrent myocardial infarction, with the numbers needed to treat on that 18, and all-cause mortality numbers needed to treat on that 30. Despite no significant difference in the reduction of LDL-C between the Mediterranean diet and the control, it is clear that the appropriate lifestyle interventions deliver far more impressive results compared with those on current medications. Given that statins give this illusion that you're going to be protected from cardiovascular disease, predispose the development of type 2 diabetes in up to 1 in 50 patients taking these drugs. In other words, 1 out of 50 people are going to get diabetes taking a statin drug. If you knew that fact before you were prescribed a statin, would you take that chance? Some people would. 1 in 50 is not real high, but it's high enough. Like, you just need to know about that. I don't think people know about that. 1 in 50 taking these drugs can cause reversible side effects in up to 29% of users. Stopping statins may paradoxically save more lives and then improve the quality of life in those taking them. So, a lot of people, they voluntarily give up their statin. I did. In the midst of my Atkins diet journey in 2004, I was on a statin medication. I was on, I think it was Crestor at the time. I've been on Lipitor. I got major joint pain and muscle aches. And so my doctor's like, oh, put you on a better one, and put me on Crestor, which was no different, same drug basically. And I was still having those pains. And so in the midst of my low-carb Atkins diet weight loss, I came off of that, and I've never been back on them again. All right, so that's cholesterol. What about calories? Is it the right target? Non-communicable chronic disease is now the biggest killer on the planet, surpassing war, tobacco, and HIV. The disease of metabolic syndrome accounts not only for most of the disease burden in the developed world, but also for the majority of the 35 million deaths per year in the developing world. The cause of this increase is routinely ascribed to the advancement of the obesity epidemic, which in turn is then talked about calories being the culprit and why everybody is so fat. But there are 4 separate lines of reasoning that question this thesis. Listen to this, you guys. 4 reasons why they think calories are not the be-all, end-all. And I know a bunch of you that watch this. There's a guy on YouTube that watches all of my little clips. And he's a big calorie hypothesis guy, and he just like berates me constantly about it. And so listen, this is good stuff. First, while obesity prevalence and diabetes prevalence correlate, they are not concordant. There are countries with populations who are obese without having diabetes, places like Iceland, Mongolia, Micronesia. And then there are countries with populations who are diabetic, but they're not obese, like India, Pakistan, and China. They manifest a diabetes prevalence of 11%. By contrast, the United States, one of the world's most obese countries, has a 9.3% diabetes prevalence. This is further elaborated by looking at years of life lost from diabetes versus obesity. Many normal weight people, up to 1/3, succumb to diabetes as well. So yeah, diabetes is often lumped into obesity. In fact, there's this term that's been created called diabesity, because they just assume if you have diabetes, you have obesity and vice versa. It's one reason a lot of people kind of look at me, oh, you must have type 2 diabetes. I'm like, I've never had type 2 diabetes. But they assume it because I have weight on the body. And so you can be metabolically healthy and have weight on the body, and you can have no weight on the body and be incredibly metabolically unhealthy. This is kind of the thing that all the focus on looking just at obesity, it misses what's going on there. And what we're talking about in this section is calories kind of being the be-all, end-all, when at the end of the day, it's not really about the calories at all. It's about the insulin resistance, which we're going to get to here in a minute. Second, although it is true that 80% of the obese population harbor at least one of the metabolic syndrome diseases, which is hypertension, dyslipidemia, fatty liver, or type 2 diabetes, 20% of morbidly obese individuals do not have anything. They're metabolically healthy, even though they're obese. And people can't understand that, how you can possibly be metabolically healthy and yet obese. People just assume fat on the body means you've got disease going on in your body. Yeah, there's something going on in there for sure, but you can have normal inflammation levels, outstanding triglyceride levels, lower insulin, all of these things, and still have fat on the body. They're saying it's 1 in 5 people who are morbidly obese actually are pretty healthy, which is why labeling just obesity being the problem is incomplete. You need to be identifying what's really going on, and it's the metabolically unhealthy. Conversely, up to 40% of normal weight adults harbor all these same diseases of metabolic syndrome. 40%. So that's, 2 out of 5 people are dealing with, that are normal weight, are dealing with some of the same kinds of health issues that is assumed of all obese people. That's fascinating. Really, really fascinating. Thirdly, the secular trend of diabetes in the United States from 1988 to 2012 demonstrated a 25% increase in both the prevalence of obese and normal weight population. Thus, obesity and calorie balance does not explain this worldwide pandemic of non-communicable disease. Although obesity is a marker for the pathology, it is not always the cause, because normal weight people are getting this too. The discrimination against fat people simply because they have fat on their body, in light of what we know about metabolic disease, that someone with fat on their body can still be healthy, and yet people without fat on their body can still be very unhealthy. It's a double standard, especially here in the United States, where people make it basically a beauty contest. If you don't look the part, oh, you must be really unhealthy. You should see the vicious stuff that's said about me online. And I've been talking about this quite a bit lately. Several people have said, well, you better not get COVID-19 because you'll die tomorrow because of your fat ass. And I'm going, okay, thank you, whatever that means. Never mind that I have incredible health markers. And yet you would look at somebody that's naturally thin and yet on the inside, incredibly unhealthy. I had a friend back when I first started blogging who owned a low-carb store in Wisconsin, I believe it was, and I went and did a book signing with my first book that I did many moons ago, and really, really thin guy. He was a tall, really, really thin guy, not too much weight on his body at all, and so he didn't have to go too low carb because he was already incredibly thin. Well, 2 years later, he had a heart attack and he died because the inflammation was in his body. I think he had a little bit of a family history of it too, but still he had inflammation in his body that he could not overcome, even though his thinness made him look like he was the picture of health. So it's just a reminder, weight is not everything when it comes to your health. Up to 40% harbor the same disease. All right, so where was I? Here it is. Obesity by inference calorie balance does not explain this pandemic. Normal weight people get metabolic syndrome too. Okay, finally, number 4, lipodystrophy is a disease syndrome characterized by too little rather than too much body fat, yet these patients have the highest risk for cardiovascular disease and type 2 diabetes, clearly unrelated to calories or obesity. So this is a condition where you have an under amount of body fat, and yet these people have an increased risk of CVD and type 2 diabetes. Why is that? It's not the fat, which is what they've been trying to tell us. Current thinking about obesity and the related diseases holds that quantifying calories is the principal concern and target for intervention. In other words, you go see your doctor, you need to cut your calories. You're going to lose weight, you need to cut your calories. And that's what they've believed. The basis for this directive is that consumed calories, regardless of where they come from, are equivalent. A calorie is a calorie is a calorie. Anybody actually still believe that? Like, have we not evolved to the point that 1,000 calories worth of Twinkies and Coca-Cola and Doritos is far different than 1,000 calories of a ribeye steak? Can we all agree that those two are not equivalent? And yet if you look at calorie apologists, that's exactly what they're saying. They're saying, oh, those two things are exactly the same. They're 1,000 calories, so they're exactly the same. Never mind the quality, never mind the nutrients, never mind the vitamins, minerals, and all the things that you get from those foods. 1,000 calories of Twinkies, Coca-Cola, and Doritos is exactly the same as 1,000 calories of a ribeye steak. If you believe that, you crazy, you idiot. Sorry, I don't need to apologize for saying what is obvious. But it's common sense to know one of these things just doesn't belong here. On the metabolic changes that result from consuming foods of different types as well, that needs to be addressed, and yet they never do. In particular, calorie-focused thinking is inherently biased against all high-fat foods. It is because fat has 9 grams per calorie, or 9 calories per gram of fat, and protein and carbohydrate only have 4. So if you want to cut calories, the easiest way is to slash your fat. But then look at what the consequences of that have been. But what we do know is a lot of high-fat foods actually protect you against obesity when combined with a low-carb diet and all the diseases of metabolic syndrome. And it's supportive of refined starch and sugar replacements, which are clearly detrimental and exclusive of their calories and effects on weight gain. So when you cut your fat, you got nowhere to go except to increase your amount of starch and sugar. That's no bueno. So shifting the focus away from quantitative, in other words, numbers of calories, towards more qualitative, which means look at the nutrition that's in the food that you consume, is what's needed. It's required to see chronic disease go into abatement. This cannot be accomplished through an arithmetic, calorie restriction, calorie counting. These balance sheets targeting calories in, calories out reinforce the message of overeating and inactivity as the underlying causes rather than the resultant effects of the aberrant physiology. I don't know about you, like I spent many a years cutting my calories, trying to count it down to the specific amount. What's funny and what a lot of people don't realize too is a lot of the calorie counts that are on food packages are grossly off. Like they don't really know how many calories are in these things. And at the end of the day, you don't really need to worry about the calories. And in fact, if you buy foods that don't have a label, you're going to probably be in a whole lot better shape than if you buy ones that do have a label. All right, let's get to the main culprit. This is a very long article, trying to finish because we're running out of time. Insulin resistance, that is the main culprit. Using the lowering of LDL-C as a surrogate marker accomplished either through diet or medicines has proven to be at best inconsistent and at worst very misguided. Furthermore, using weight or BMI as a surrogate marker has also been ineffective. While some people lose weight acutely through self-imposed dieting, they usually gain it back, often with a worsening of their metabolic state. I would say when they go on some kind of a low-fat type of diet, where they're eating a lot of carbohydrates, the calorie restriction will help them lose weight, but the carbohydrates are making their metabolic health worse even while they're losing weight. And this is something people don't get either. Yeah, you can lose weight on a low-calorie, low-fat diet. You absolutely can. But what you're not doing is you're not improving your health. You're increasing your blood sugar, you're increasing your insulin, you're increasing your inflammation levels, and in the end, those things are going to overtake you. Never mind all the mental health effects of eating low calorie, low fat, all the I'm hungry all the time, that your willpower will only just last for so long before you burst and go have a binge. We should examine other risk factors which more clearly drive this pathophysiology. The risk factor that has been most consistently associated with cardiovascular disease, type 2 diabetes, and obesity is insulin resistance, where we have an impaired biological response to insulin. In fact, this plays a primary and a causative role in the pathogenesis of hypertension, dyslipidemia, fatty liver, type 2 diabetes. All of those things combined is called metabolic syndrome. We propose that the insulin resistance is the most important predictor for CVD and type 2 diabetes. It is a view that is strongly born out of the work of Gerald Reaven and colleagues. In a seminal natural history study, these researchers took a group of healthy people who were insulin sensitive and free from heart disease. After 5 years, they found that none of them who remained insulin sensitive had developed heart disease, whereas 14% in the highest category of insulin resistance did develop heart disease over that same period. Another study, up to 69% of patients admitted to a hospital with acute heart attacks were found to have metabolic syndrome, which was associated with the risk of death or readmission in the following 12 months. So they go on and on about some of the other trials that are out there, but they point to the excessive consumption of refined carbohydrates and the resulting glycemic load that overwhelms the hepatic mechanisms that regulate your blood sugar. In other words, your liver's got to pump out more and more sugar trying to deal with all this that you're feeding it. Evidence surrounding the use of a low-carb, high-fat diet for the prevention of treatment of CVD, type 2 diabetes, and obesity is now accumulating. Unfortunately, other than Brazil, there has been little change to anybody's dietary guidelines, which continue to recommend a low-fat diet, which often pushes people to consume more refined carbohydrates, including sugar. And the 2020 dietary guidelines in America do not look any better. They're going to be more of the same. In fact, I did a recent Jimmy Rants where they're lowering the fat even more. Furthermore, dietary guidelines, as well as recent advisory by the American Heart Association, recommend replacing saturated fat with unsaturated fat in order to lower LDL. They've been pushing that forever. They also want people to be consuming more vegetable oils and margarines rich in omega-6 fatty acids. But the consumption of omega-6 PUFAs skyrocketed in recent decades, and it dwarfed the intake of omega-3s. And we know this ratio needs to be closer to about a 1-to-1, but unfortunately it's more like 20-to-1 in the westernized world. Minimal exercise can also help to reverse insulin resistance. And it's time we try to redefine these risks with CVD. One of the safest, most effective ways to reduce your risk of heart attack or stroke is to eat a high-fat, low-carb diet and to engage in regular exercise. At the very least, exercise interventions are often similar to drug interventions in terms of mortality. Currently, 75% of healthcare dollars are spent treating chronic metabolic disease. If nothing else comes out of this COVID-19 thing, I hope we see where metabolic disease is identified as a key player in why we dealt with this worse than we needed to. And they're right, 75% of every dollar. 75%, let that sink in. 75% of healthcare dollars has to deal with your choice to eat poorly and to live an unhealthy lifestyle. Can you imagine the savings to our system if people just started eating better, if they just started embracing real whole foods and doing something before it gets to the point where you have to have a medical intervention? Instead of funneling billions of dollars to new drugs and development, perhaps more of that money could be spent encouraging the implementation of any policy directive that encourages widespread behavioral change to reverse insulin resistance. Even a 20% reduction in sugar consumption would add up. Public health should work primarily to support the consumption of real food that can help protect against hormone and mitochondrial dysfunction, and not continue to promote this failed calorie-directed message that blames the victim and exacerbates the pandemic. Then and only then might we achieve the goal of attenuating this prevalence of cardiovascular disease and all the other chronic diseases of the metabolic syndrome. So again, guys, this was written in the Pharmaceutical Journal by Marianne Damasi, Robert Lustig, and Asim Malhotra, all medical doctors who are very concerned about the messages of cholesterol and calories being put out there when it's not about either one of those at all. It's about the insulin resistance. Okay, we're running out of time. Let me pop over to Instagram first. And if we run out of time, Facebook and YouTube Live, I will come to you after the show and we'll keep answering your questions. But I definitely want to go to Instagram first. Thank you guys for being here. Welcome in, welcome in. JimmyRants.com, by the way. If you missed any of the past episodes, go back and watch the old ones. Will you post a link to the study, says Pink Puggy Pundit. So it's going to be a little bit hard to post a link. Instagram does not make it easy to post a link. But if you Google the cholesterol and calorie hypotheses are both dead, if you just Google that, all in quotation marks, you should be able to find this paper that was in the Pharmaceutical Journal. So it's pharmaceutical-journal.com if you want to look it up as well. All right. Bonnie says, wow, I have chronic pain, fibromyalgia, osteoarthritis, and something with my shoulder. Cholesterol is high, but may be cause of inflammation. You know, Jimmy, that I'm strict keto. Well, I hate fibromyalgia as a diagnosis, by the way. I think fibromyalgia is a catch-all for the doctor doesn't know what's wrong with you, so they throw it in the fibromyalgia. I'm not telling you what to do with the statin, but I think it would be something that would be worth experimenting with, at least for a couple weeks, if you want to choose to do that, Bonnie, to see. Oh, she says, I don't take a statin. My heart test, the heart scan test came out with a 0, which is perfect heart calcium score. George says, my cardiologist prescribed a statin to lower my LDL down to 70. All my other markers are good. Triglycerides 59, HDL 69, A1C 53. I've been keto for 3 years and lost 180 pounds and have kept it off. Yes, you are a champion, George. That's awesome. Jillian said, my sister did a research paper on the bias of doctors toward the obese. It's really eye-opening. Yeah, I've looked at some of those studies and some of the language. I know at the obesity conferences now, they're educating medical professionals about how you're supposed to talk to obese patients. And the number one thing they say is, don't tell them they're obese. Like there's kind of this kind of negative stigma when it's related to telling a patient they're obese. It's almost like cussing them out. Carriana says, great topic. We should all be shouting this from the rooftops to combat the conventional message. Well, Carriana, you know this has been my heart cry forever. I've been talking about this for a long time, but it's good to see medical doctors kind of getting in on the action now, standing up for what's right. Kelly says, what do I do about super low glucose? Mine is 50 to 69. Well, that's a general question. We only do general questions on Fridays with the Ask Me Anything. But if you have that low a cholesterol or blood sugar, I need to know the context of it. So when you write your question, tell me when you're testing, tell me what your normal blood glucose is. I need more information. It can be hard to answer that. All right, so thank you, Instagram. We still have a few more minutes, so let's go over to my Facebook page next, and we have time, you guys, over on YouTube. We'll come to you. Regardless, we will come to you after the show is over on Instagram. All right. Welcome in, guys. Thank you for being here today on Jimmy Rants. Let's see what you got to say about this one. Got a lot of people saying hi. Amy says, I went off my statins the last time I had my labs checked. My total cholesterol was 180, and I feel better being off of them. Well, 180, that's great if you want to keep it there. Again, there is evidence that having a little bit higher cholesterol is probably a good thing, but rock on if you got it down to 180 and you're happy about that. Marianne says, FYI, YouTube not sending me notifications will not let me adjust my subscription. Well, a lot of people on YouTube, they did some shenanigans recently. If you totally unsubscribe from my channel and then you resubscribe to my channel and hit the bell, you should be able to get a notification. I'm assuming all of you guys watching this on YouTube Live, you got notification of it because you did that. So try it again, Marianne, because a lot of people are reporting that did fix it for them, but thank you for letting me know. Emily says a lot of insurance pay for some cholesterol meds as a preventative medication. They still push using them because physicians get kickbacks. Yeah. Said that very thing during the Jimmy Rants. All right, thank you guys here on Facebook. All right, let's go over to my YouTubers. Let's see what you guys have to say. A little bit harder to see the YouTube comments. I'm going to pull you in a little bit closer so we can see what you had to say here. Read The Big Fat Surprise by Nina Teicholz. The Nutrition Hogwash is Scary. Oh yeah, that's a great book, by the way. Selena says, recently my Harvard-trained provider recommended Repatha since other statins make me hurt. I said, thank you for your sweet concern, but I think I'll just keep my cholesterol. Oh, I love you, Selena. That is awesome. And Keto Grace says, hello from Utah. Well, thank you for being here, you guys. All right, so let me go back over to my guys over on Instagram Live. See if you got any other comments about this topic. And it looks like you do not. So guys, what do you think? I mean, isn't it great? We've got medical doctors that are basically saying, hey, look, we've got it all wrong when it comes to cholesterol. Bell not working, marked out due to kids video. Yeah, Mark, if you'll unsubscribe from my channel and then resubscribe to my channel, that is supposed to fix it, and then the bell should work at that point. They changed the setting over to the kids, but because we changed it back to the health category, you should be able to do it now. Thank you for letting me know, but yeah, YouTube really screwed me over bad. Okay, the cholesterol hypothesis, totally bogus. The calorie hypothesis, totally bogus. Now, does that mean cholesterol means absolutely nothing? No. Does that mean calories mean absolutely nothing? No. But it means their relevance that they've been pitched to us for so many years is not as great as we've been made out to be. But look how convenient the cholesterol hypothesis and the calorie hypothesis makes it for the pharmaceutical companies and the food companies to make out like gangbusters. The cholesterol hypothesis led to the creation of a drug that wondrously lowers your cholesterol. The calorie hypothesis led to the industry that now gave us 100 calorie packs. Has anybody ever bought like one of those 100 calorie packs? Like, why? Like, what are you trying to prove there? As the funniest one to me was when they made those little short cans of Coca-Cola. So you had a 100 calorie miniature Coca-Cola can. I'm going, what's the point? I don't get it. That's when you knew the madness was crazy, when they started doing 100 calorie packs. Mark said that works. So yeah, if you're watching on YouTube, please go unsubscribe, resubscribe, and hit the bell, and it'll work. So, okay. Good stuff today, right? Love this article. Insulin resistance, guys. That's what we need to be shouting from the rooftops and letting people know that is what it's all about. That's it for this episode of Jimmy Rants. JimmyRants.com is the website. As always, you can go follow me over on Instagram because that's where this show begins. I'm over on Instagram at Livin' Low Carb Man, LIVINLOWCARBMAN. Once you are there, engage live. We go live at 11 a.m. Eastern, Monday through Friday. I occasionally throw in a 5 p.m. Eastern time and sometimes on the weekends, but definitely Monday through Friday, 11 a.m. If you missed the live, you can watch it on replay for up to 24 hours. After 24 hours, pop on over JimmyRants.com. We house all the past episodes there. They're also over on YouTube. And again, thank you to Facebook Live and YouTube Live for joining the simulcast of Jimmy Rants. So go check it out on YouTube. Type in a keyword, Jimmy Rants. You will find the show. So guys, that's it for now. We'll be back again real soon with another episode of Jimmy Rants. See ya. All right.